Buongiorno. Sono molto felice. Essere qui. Tutti voi. I shall try to give the rest of the lecture in English. So, Enzo, Francesco, I'm delighted to be here. It was a marvelous meeting in this beautiful city. But let me take you to another beautiful city. This is the quayside at Newcastle upon Tyne. I took this in the early morning, looking up through the bridges. There's a famous Tyne Bridge, but this is our Millennium Bridge. It's a beautiful structure. But the thing about a bridge is it takes you from one place to another. And I'd like to start off considering the conventional view on type 2 diabetes. This lifelong, inevitably progressive disease, best illustrated by data from the United Kingdom Prospective Diabetes Study. Over 15 years of the follow-up, HbA1c rose progressively, both in the group that had conventional treatments, that was a conventional target for treatment, or the group that had intensive targets. And so this group had lots of medication, that rather less so. But just look, these lines are parallel. This onward progression seems inevitable. And indeed, they only flatten off, these lines, because at 10 years, 50% of all people were on insulin. Downhill progression. And you might ask, is this due to the insulin resistance of type 2 diabetes or the insulin secretion? Well, we've known for a long time insulin resistance doesn't change throughout the course of type 2 diabetes. But data from UK PDS showed very clearly, this is model data from HOMA, that there is a downhill progression. But look at the starting point at diagnosis, because everybody was taken from diagnosis in UK Prospective Diabetes Study. At diagnosis, beta cell function was already down to 50%. And so the story goes, this is due to death or apoptosis of the beta cell. But suddenly, in 2006, I saw some new data which caused all the ideas I'd been accumulating on the physiology underlying diabetes over the last few decades. It caused them all to come together. And I could see a possible hypothesis of the etiology of type 2 diabetes. Now, we could test this hypothesis, and indeed, that's the only point of having a hypothesis. You need to try and destroy it. I could destroy this hypothesis by putting people on a low-calorie diet, and if their fasting plasma glucose did not become normal in 7 days, the hypothesis was no good. And this is what happened. Here we have the counterpoint study. All the hypoglycemic agents were stopped on day 1, and fasting plasma glucose normalized. This was on approximately 700 kilocalories per day. I had designed the diet so it would be humanly possible. We're working with real people who are going about their everyday lives. So we needed to adopt a pragmatic approach. And on the basis of what people have been telling me over the previous 30 years of being a consultant, then I put it all into practice. People lost 15 kilograms in weight over the entire 8 weeks. But just look, at 7 days, fasting plasma glucose was normal. Now, the design of the study was to try and follow the pathophysiological changes so that if we got rid of diabetes and everything went back to normal, we would be able to see the stages of progression in reverse. And that would lead us to the etiology of type 2 diabetes. So, developing new magnetic resonance methods and other techniques, we were able to say that that very rapid fall in plasma glucose was due to a rapid fall in liver fat, 30% decrease at 7 days. And there was complete normalization, not a significant improvement, complete normalization of liver insulin sensitivity. over the whole 8 weeks of the study, there was a very gradual fall in the level of fat in the whole pancreas. The acinar cells and the islet cells take up fat to a similar extent. There was a very gradual return of first phase insulin response. I'd like to show you just 3 pieces of data from this study, because it really underpins the understanding of what you and I might be advising individual people in the clinic. Let's start with an MR scan, an MRI, but not just any old MRI scan, because in this cross-section across the abdomen, every pixel is color-coded for the concentration of fat at that point in space. And the key is over here. If that point of space is 100% fat, it's red. And as we go down, it will be black if there's no fat there. So if we look inside the aorta, for instance, there is no high concentration of fat, whereas in the front of the stomach and the back, of course, subcutaneous fat is almost 100% fat. But the point of this slide is here. This big organ, what an unpleasant colour. It's about here. And indeed, this individual had 36% liver fat. It was shocking to us to discover how common it was for liver fat to be so high in people with very ordinary type 2 diabetes. What happened over the 8 weeks of the study? Well, the repeat scan at 8 weeks was this. You see, the liver fat has almost completely disappeared. 2% liver fat. So we know why the liver insulin sensitivity, which over the previous few years, several groups, including our own, had shown was underlying liver insulin resistance. We know that the liver fat would go away, liver insensitivity would come back. Now, there's a lot of talk about muscle insulin resistance, and it's become a bit of a bandwagon. So let me show you what happened to muscle insulin resistance during counterpoint. Almost nothing. Muscle insulin resistance is a background property of the person. And indeed, when I was able to plot using data from Leaf Group's Botnia study and a few other large studies of clamps, the normal distribution in the population of the M value, you could see that in type 2 diabetes, it was just a bit skewed to the one side, but entirely within that population. So there was no great surprise to me that the muscle insulin sensitivity did not change, even though fasting plasma glucose had become normal. So here we see a very important point. But let me take you to the really important organ. What's the most important organ in type 2 diabetes? Well, of course, it's the pancreas. And if we evoke a first phase insulin response by raising plasma glucose quite suddenly, just by 2.8 millimole per litre, then in non-diabetic controls, we get this zip first phase response, peak at about 6 minutes. And we've known for ages that in type 2 diabetes, that is absent. And so the story goes, is absent for good and won't recover. So what happened? Let me just take you through from baseline to 1 week. Hello, what's this? This baseline's dropped, and you might imagine something not statistically significant. Hello, but not statistically significant. But by 8 weeks, this was similar to normal. Not quite normal. The normal peaked at 0.6. This is 0.45. But a dramatic increase. So the beta cells had woken up, and this sequence allows us to observe that for the first time. What was this hypothesis that led me to do the counterpoint study? Let me just take you through the steps. It seemed to me that type 2 diabetes, now I'm talking about classic type 2 diabetes, dissect off autoimmune diabetes, of course. We're talking about what we recognize as ordinary type 2. It never develops unless people have been eating a bit more than they should have done for their own bodies over many years. But if there is pre-existing insulin resistance, there will be a shunting of these extra calories into liver fat. And that will start a cycle, because if liver fat starts building up, then we begin to get insulin resistance. And as soon as we have resistance to insulin, what happens? Well, plasma glucose tends to creep up a bit, and because of this, we'll actually further stimulate this process. It's just a fact of life that insulin stimulates this process of de novo lipogenesis, transferring excess glucose that can't be stored in muscle as glycogen because the muscle is insulin resistant, transferring that into fat. And I'll return to that at the end of the talk. But eventually, plasma glucose will creep up, and that process will grind onwards for years. But of course, this liver fat does not just stay in the liver. It is secreted. Now, for all the young people in the audience, I can tell you a secret. When I was a medical student, I thought this lipoprotein business was too complicated to waste time on learning. I thought I could pass the exam without it. I did the same for my specialist exams. Unfortunately, about 3 years ago, I had to give a lecture on it. And so I had to wrap cold towels around my head and try and understand it. I discovered that it was all complete nonsense. The description in the textbooks has been written by biochemists who are describing a crashingly simple process. There is only VLDL, triglyceride, that's secreted from the liver. Everything else has the triglyceride lopped off step by step. And of course you can classify those, but it doesn't matter. Now, HDL is a completely separate entity, perhaps not even a proper lipoprotein at all. So here we have the normal process of the liver putting out energy for the body, but if that's high, that will be high. Normally, it would go into subcutaneous tissues. But if the subcutaneous stores are relatively full, these adipocytes are already bulging, even slight inflammation as a result of that in subcutaneous tissue, then it's got to go somewhere else. And it will silt up, excuse me, in all the ectopic sites of the body, the visceral compartment, epicardial fat. But of course, the pancreas is exposed too. And the hypothesis was islet fat and total pancreas fat would go up. A couple of days ago, Roger Unger was mentioned. He is one of the shining lights of diabetes. He's a thinking man who probed the physiology, and he did some work on isolated islets, which showed quite clearly that fat would decrease the acute insulin response. What if that fat caused the acute insulin response to a meal to gradually go down? Of course, plasma glucose would stay up for much longer after a meal. That would cause insulins to go higher. That would stimulate the liver fat. And these vicious cycles would grind miserably on year. Well, that was the hypothesis that led me to do the counterpoint study. But can we take a step back? Just imagine your clinic. People come in all sorts of different shapes and sizes. How does this relate to body mass index? Now, there is a belief abroad that type 2 diabetes is caused by obesity. So we pause for a minute and consider that, because in the UK, the average BMI at diagnosis is 30. Half of this whole type 2 population are non-obese. The other half, yes, are above 30. And if we look at the non-diabetic population, then in the US, several studies put together show 73% of morbidly obese people do not have type 2 diabetes. We've been deluded by this. So let me look at the population distribution of BMI. And in this slide, I've abandoned the usual line that describes a population distribution and have tried to get down to the level of the individuals. Now, for the purpose of this and the next slide, a red blob means that that individual has type 2 diabetes. You might say, hang on, that's very odd because the median BMI in this distribution is 27. That's too low. In fact, this is a BMI distribution of UK PDS. Most diabetes specialists do not realise that UK PDS was conducted on 36% with a normal BMI, and only about 33% who were obese. And yet, there's been a blithe assumption that that population was the same as today's population. In fact, as I'll show, it doesn't matter. What we have here is a population distribution. And let's park it at the top here. But let's play some thought games. What if each of those individuals lost 15 kilograms in weight, just like in the Counterpoint study, and got rid of their diabetes? Then they would be here, and the blue circles indicates no diabetes. But of course, it's the same person. Now, that's all very well, and you might say, well, the median BMI has gone down to about 24. But I'd like to take 3 individuals to illustrate the point. Let's take Giuliano here, Maria, Antonio. Now, Giuliano, a merry man who is not small, lost 15 kilograms. That's about 4 BMI units. And on the way, he lost his diabetes. Maria was overweight, 29, and went down to just over 25. And Antonio went from 24 down to about 21. And they lost their diabetes. Now, if you apply conventional thinking, or even ask a population expert what has happened, they would say, well, nothing's happened, because Giuliano is still obese, Maria is still overweight, Antonio should not have lost weight. He was a normal weight. Now, quite clearly, this is ridiculous, because at the age of 21, Antonio had a BMI of 21. He has put on excess weight for him. Just imagine my metabolic state if my BMI went up to 21. I'm not built to cope with that. So we need to see that individuals are individuals. Type 2 diabetes is not particularly due to obesity, a fixed definition of BMI. It's due to having more fat than the individual can carry safely, perhaps the size of the subcutaneous stores. It's useful to coin a phrase to describe this, and I would suggest that we're describing the personal fat threshold. Now, I pause particularly on this slide because I found that in the clinic, people respond very positively to this explanation. Following on from the question that must have been put to you, why have I got type 2 diabetes? All my friends are fatter than me, and they don't have it. Well, it's a matter of the personal fat threshold, the ability to store fat safely or not so safely. Let's go back to the Newcastle Quayside. What we've been talking about is metabolic balance, and perhaps our Millennium Bridge is a nice visual metaphor for balance as it rotates around its axis to allow ships to go up and down the River Tyne. But here we are in a situation of metabolic balance restored. How about the population? What I've shown so far are studies done in a research centre. Admittedly, the participants were living everyday lives. We did several other studies with the same sort of format to learn more about this phenomenon. But the question was pressing. Is this something that could be used in routine clinical practice? Is it something that we could roll out in general practice in the UK? And in order to answer that question, I worked with a colleague of mine from Glasgow, Mike Lean, who is an obesity specialist, interested in nutrition. He had been trying to deliver a similar program into primary care. We were able to combine forces and carry out the direct study. Here we see the plan. General practices were randomized either to intervention or to control. Control had best management according to current NICE guidelines. Intervention had a very similar weight loss program to that which I'd originally devised, to achieve an aim of 15 kilograms weight loss and then keep it down. There were 149 people in this group, 149 people in that group. Here we have the basic design, and these people had had type 2 diabetes for less than 6 years and were on oral agents, not on insulin. Now, we've learnt in the background that people on megadoses of insulin respond extremely well to this. They come off their 300 units a day because these are the most insulin-resistant people. Stop the insulin at a safe point of the diet, usually a few days in, and plasma glucose returns to normal. So that is what we've learned. The intervention group, here we have diabetes less than 6 years. That's important because along the way we had done further studies looking at the duration of diabetes, which was compatible with remission. And we found that over 10 years, remission was much less likely. So we hadn't finished those studies before we had to design direct. Arbitrarily, we selected 6 years. And this shows the overall results in the intervention group at 6 years, showing the percentage of people in remission, and it's by the amount of weight lost. And if they achieved the aim of 15 kilograms, you can see that 70% had no diabetes off all treatment. All the tablets were stopped at the time of commencing therapy, commencing the diet. 10 to 15 kilograms, not bad. And in fact, if we combine those to say, okay, what if people lose 10 kilograms? Well, 2/3 of people with early type 2 diabetes go into remission. 5 to 10 kilograms, that's really not enough, but some people will flip. Less than 5 kilograms, forget it. Now, bear in mind that most therapeutic trials of the previous weight loss agents were scrabbling around in this sort of region, not effective. Very excitingly, some of the data we heard a few days ago show that the new agents can bring about this amount of weight loss. So we're entering an era where this may be feasible beyond what I'll be talking about, which are people who are able to do this purely by their own motivation. Let me show you some trajectories. The group of people in the intervention group who did not achieve remission had only 5.8 kilograms of weight loss, and this is at 12 months. 24 months, even less. So the people who didn't go into remission were doing so largely because of weight in the overall study. These are intention to treat data, by the way. There was a very interesting group who lost a pile of weight, but unfortunately put on the weight. Unfortunately or fortunately? Well, unfortunately for the individual, because they'd usually hit a life event, finance, illness in the family, whatever, and the weight had gone back up. But very fortunate, because we were able to observe these people whilst type 2 diabetes came back again. Here they are. They'd lost 12 kilograms as a group and had lost most of that by 24 months when the diabetes had come back. That small group is really important. Actually observing type 2 diabetes develop and seeing if these wild ideas might be correct is very useful. And finally, there are people who were in remission at 12 months and also 24 months. In the whole study, 46% were in remission at 12 months. 36% were in remission at 2 years. Now, taking 1/3 of people out of diabetes, allowing them to say, I don't have diabetes, they don't have to pay more for their holiday insurance. The commonest comment fed back is, I feel 10 years younger. And also, on a National Health Service scale, this is a potential huge saving. And that's why the National Health Service in the UK is just about to roll out a large pilot scheme of trying to find out how to incorporate this into routine care across the country. But let's go further and look at some of the mechanisms. Now, for the half of the intervention group who lived near Newcastle, we did detailed studies. What happened in the liver fat and also the export of VLDL? Well, here I'm showing data on the people who responded. They achieved non-diabetic HbA1c less than 48 and a fasting plasma glucose of less than 7 millimole per litre. So they no longer qualified for the diagnosis. Then we have the non-responders who are still diabetic. Well, in fact, the weight loss produced identical effects on liver fat. And yes, there was a moderate difference between the groups as we progressed, but it was not a wild difference. So liver fat correction was not the yes-no of diabetes remission. How about the export of fat as VLDL? Well, no, once again, there was a fall in both. It was greater in this group, but it was generally similar and was still lower at 2 years, even in the non-responders. So we have to look elsewhere. Well, liver fat exporting out of the liver. How about the pancreas? Well, let me just show you the correlation between change in liver fat and change in pancreas fat. And you can see that as the liver fat falls, the extent of fall correlates with the extent of change in the pancreas. I just draw your attention to the fact that this change is numerically far smaller than this. The pancreas, in the background, is a fatty organ. It has isolated adipocytes scattered throughout, and we're not measuring, we're not talking about those components. What we seem to be talking about is an intracellular distribution of fat, and a very small change is being observed here. So, taking away the fat, what happened to this functional capacity of the beta cell? Now, we can get at this by virtue of extending our insulin secretion test, raising plasma glucose further, plus 5.6, and then giving a blast of arginine, and that gives a measure of maximal possible insulin response. Now, at baseline, you will not be surprised to learn that it was down here. The non-responders did not increase. So the capacity to respond is actually located inside the beta cell. If you have susceptible beta cells and excess fat, you'll get type 2 diabetes. If you have non-susceptible beta cells and excess fat, you won't get type 2 diabetes. You're part of the 73% who are grossly obese but non-diabetic. So here we see the responders increasing their capacity. I've said beta cell functional capacity. How closely to normal did this go? It normalized over 12 months. You'll note that the immediate weight loss period, tests were done about 5 months. So that's after the weight loss and then after a period on a normal isocaloric diet. No significant change there, although there was a linear increase continuing to 12 months. Thereafter, after this recovery, beta cells stay fine. So take away the stress. These beta cells that have previously been said to be dead recover. We might be tempted to quote a famous quote, and that is that rumours of my death have been much exaggerated. So here we have a mistaken concept of beta cell death. Coming on to the matter of observing type 2 diabetes, let me show you in 2 slides what was happening. Plasma VLDL rose sharply prior to the recurrence of type 2 diabetes. The pancreas fat, which in the responders had dropped by about 1.7%, had entirely gone back to normal. That's the baseline in the relapses. So in other words, they've gone back to their excess fat. But if the twin cycle hypothesis is really right, we should see something else. We should see the beta cell function going off, and we should see an effect of the de novo lipogenesis. Just look at this. These relapsers had gained beta cell function. This is first phase response, and it had gone away again. There's no doubt why the type 2 diabetes came back. If it was due to VLDL, and if that was due to de novo lipogenesis, think back to your biochemistry. What is the product of de novo lipogenesis? Well, it's a C16 saturated fat, palmitic acid. And that just happens to be the most stressful fatty acid on the beta cell. Did the palmitic acid content increase in the VLDL? Yes, here we have de novo lipogenesis revving, driving on the type 2 diabetes. I think we could say type 2 diabetes can be seen to be a simple disease, easily explicable in terms of understandable mechanisms. But what's going on in the beta cell? Well, here we have metabolic stress, getting this healthy beta cell to be loss of function, but this is reversible unless it goes on too long. And we know from a variety of studies, especially those of Mimo Elakili in New York, that a null cell will result. Clinically, what do you see? Well, you see people who have a reversible condition if the metabolic stress is removed, but we can't always tell how well that individual is going to respond. Over a period of time, it will certainly become irreversible. And my final slide is about this diet. It's not really a diet. It's an understanding of what needs to be done to achieve a step change in weight. And to do that, it's got to be simple. We used a liquid formula diet. It's not associated with hunger. It's not associated with the day-to-day burden of decisions, which are the 2 big problems people have told me that prevent them losing weight. It's got to work in real life, and this point is vital, because individuals don't follow diets. Do not send an individual to a dietitian. Families eat as families. So for this major change of lifestyle, we need the spouse or the partner on board. Duration is time limited. You need to set aside time to get rid of your diabetes. And there's some good news. Please, no additional exercise. Now, this causes jaws to bounce off the floor, and I get attacked by exercise physiologists. But the best kept secret in the whole of the obesity field is that when overweight people commence an exercise program, compensatory eating actually renders the effect almost null in terms of weight change. And back to the key slide. Here we are. I've taken you on a journey of the practical physiology of type 2 diabetes, which is relevant for the person in front of you. And I think we can see some bottom lines. Type 2 diabetes is a simple homogeneous condition occurring in genetically and phenotypically heterogeneous individuals. Beta cell recovery continues for at least 12 months after removing the metabolic stress, but those beta cells go back to normal. So I think we can approach the diabetes clinic with a spring in our step compared with the depressive aspect that we had before. Thank you.
Thank you, Professor Taylor, for this beautiful lecture, rich of data, some unpublished data. Thank you for sharing with us. This lecture is now open to discussion. Professor Ferranini.
Very well done, Roy. Thank you very much. I'm here. It doesn't matter where I am.
Oh, Ellie. Hello.
You seem to put a lot of emphasis on this pancreas fat. But magnetic resonance doesn't tell you where the fat is. And in fact, if you go back to the literature, it's only the Zucker-Rat model that shows, Roger Anger's model, that shows an accumulation of fat within the islet. But if you look at all studies done with human islets, you don't see any fat, or very little, to my knowledge, either in the interstitium of the islet or within beta cells. So I wonder why you are not also stressing that what you're seeing is a relief of glucose toxicity, because the first thing that changes before fat changes is your glucose levels.
Yes. Clearly, once type 2 diabetes develops, there is a combined effect. You've got the fat, you've got the glucose, and that is absolutely right. However, raised glucose cannot explain the etiology of type 2 diabetes. Glucose is normal before it starts rising, and yet the process gets underway. Now, the matter of the measurement of pancreas fat, yes, we're looking at whole organ fat. We use a particular technique that we've published that allows clarity that we're not measuring lumps of fat within the islet. We're measuring it within cells that are distributed throughout. If the pancreas is prepared in a way that preserves fat, and this isn't usually done, then you can see lipid droplets throughout the islet. If human beta cells are exposed to a very modest increase in fatty acid content, the fat uptake of the pancreas is really very marked, and the insulin response of those exposed islets goes down. So we have definite evidence that in human beta cells, exposure to fat can bring about a change. But more than that, it was really important that we demonstrated that what we're measuring in whole organ fat is not merely an effect of people having lost weight. And so we did a study with equal weight loss in people without diabetes and with diabetes. And guess what? The pancreas fat did not change over 8 weeks in the non-diabetic people. In the diabetic people, it started high and went down. So we have reasonable evidence. But, Elliot, this is a hypothesis. It ties things together in such a way that we can explain what is happening in populations. If a population is overfed, type 2 diabetes shoots up. Just look at the Pima Indians. And then if a population is starved, like after war, and especially the beautifully documented case in Cuba in the 1990s, then type 2 diabetes rapidly goes into reverse in terms of incidence. So, yes, I agree it has to be combined effect in type 2 diabetes, but the initiation has to be the fat alone.
If I can add a comment on this, I agree, of course, also with a comment, but when you work with isolated islets or also with enriched population of beta cell, okay, if you then had fat or palmitate, for instance, without having any fat accumulation, you have a negative effect on beta cell function, due also to the competition between fat and glucose metabolism in the islets. And being so critical and important, the glucose metabolism, the ATP rise due to glucose, then you block insulin secretion, but not for fat accumulation, but for fat interference with glucose metabolism. That may be an alternative way of of looking at the picture?
Yes, thank you. I think it's worthwhile pointing out there are two very separate things. One is that the fat supply to the beta cell will be increased because of the raised plasma VLDL triglyceride. So the constant minute-by-minute supply will be raised. In addition, with the MR, we observe this change. Yes, we are aware of these two separate features.
Ricardo?
Thank you, Roy. This has been a very interesting lecture, very stimulating. I think that you are also helping us to dispel some misconception in the field, and this is very helpful. I will go back to the chain of the events you are proposing. Many people working in the field of adipocyte biology will tell you, why do you put adipocyte failure, fat tissue failure in storing fat so late in this natural history? Many people will argue that actually the first event, the first vulnerable spot, is just an adipose tissue. When it fails to store fat, at that point there is the possibility for liver to accumulate fat. So the first event, the first vulnerable spot may be just adipose tissue. And I'm not sure that at this point of our knowledge we can say which comes first. I wanted to hear whether you agree with this point. The second is you are perfectly right in stressing the role of beta cells in tracking. Diabetes goes away, diabetes goes back, and the beta cell really heralds this phenomenon. But to some degree, talking about beta cell failure and talking about the presence of diabetes, to some degree, is a sort of tautology. The state of diabetes, being diabetic, implies always that the beta cell is not working properly. And on the other hand, if you have a reversal of diabetes, it's almost impossible to think of it without a recovery of function. What I'm saying, of course, beta cell remains at the center of the stage. But we should understand is what makes beta cell change is its behavior. And so far, I think that we have no clear ideas about human type 2 diabetes.
Now, taking the second point first, beta cell biologists, by and large, hate this idea because most of their work manipulates glucose, which is so easy to manipulate. And as Ellie points out, that is very solid data. And so amongst the most vehement referees all the way through have been basic beta cell biologists who think this cannot be so. But I think they're not seeing the whole picture. So there's the beta cell question, and yes, we have some hypothetical concepts here. And as I mentioned, it's our job as scientists to try and destroy our own hypotheses and really test them hard. But the position we're in at the moment is seeing very clearly that people can get rid of their own type 2 diabetes if they want to and keep it away. And the proportion of people who are who want to do this is far greater than doctors realize. It's somewhere around the 20% mark, in my estimation. And if we say that maybe half will actually succeed for various factors, taking out 10% from the whole population is really important. So it's a choice. Coming on to your point about which comes first, I agree entirely. I think the overfull adipose organ will be stoking up the initiation of liver fat and the genesis of liver insulin resistance. So the first step is likely to be that. I've simplified in order to just get across the points, but I agree that that's a player.
Stefano, please, short question and short answer because I have a long queue.
Right. Thank you very much. Very quickly, I'd say. First, comment about the accumulation of adipose tissue within the pancreas and even more in the liver. I think that, it may be just metabolic as an action, but could also be related to inflammatory response. And at that point, if you have an inflammation, it may not really be so So important whether it is inside the beta cell, around the beta cell, or around the islets. And I'm wondering if you are factoring that in. The second, you have been showing that Giuliano, Maria, and Antonio all were responding in some way. But when you look at those at the individual level, do you see the same changes in VLDL and so on and so forth? So is the thing common through all of them? And the final question is, what is the role then of the genetic background? Because you can have heterogeneity in the genetic background that may account for differential response in terms of the lipid toxicity, or at least in terms of the persistence of the effect that you can see by reduction in the calorie intake.
Yes, we can be quite confident that Giuliano and Antonio are exhibiting the same mechanisms. Given that, we're looking at a fixed weight loss. A person coming down from 160 kilograms to 145 will get rid of the diabetes. It's not anything to do with an absolute, nothing to do with obesity as defined. And so the person who is 70 kilograms, they need to lose about 15% once you get into that lower range. They go down to from 70 to maybe 58 kilograms, exactly the same thing. We see the drop, especially in plasma triglyceride, which is easy to measure in the clinic. So, yes, I can be reasonably confident. I just point out that my index patient from 14.5 years ago actually started with a BMI of 24. That person has stopped the agents at the time, still has a BMI of 24, still has no diabetes. So I think we can be reasonably confident about it, but at the moment we're conducting a further study to look at people with BMI 27 and less, direct was 27 and above, in order to be certain about that. Anecdotes are fine in medicine and open up ideas, but we need to test them convincingly, and I hope we're going to do that.
Usually, we are pretty much convinced that NAFLD is strictly associated with the risk of diabetes. And generally, the amount of fat in the liver increases before the diabetes occurs. Have you got any serial measurement of liver fat in patients who relapse in order to see whether the liver fat precedes or follows the appearance or the reappearance of diabetes? And the second question, how could you manage the return to a normal diet in these guys, which is quite difficult to move from a very low-calorie diet to a normal diet without exceeding and thus putting at risk what you have got?
Thank you. So, first of all, the liver fat. Yes, in people who relapse, liver fat does increase. It doesn't increase completely back to baseline, but it certainly increases. But it's worthwhile just pointing out that it's not the fat itself which is causing the problem with insulin resistance. The fat is triglyceride, and that's what we're measuring. What's causing the problem with the insulin resistance is the related di-acylglycerol, maybe ceramides, other moieties. And so as soon as the fat starts getting in excess, you'll have a rise in those intermediates first. So we do see a rise. It's not a complete rise, but I think there's a reason for that. With regard to your really practical question, it's tough to switch from a low-calorie liquid diet where you've seen the weight loss fall so fast. Most people do not want to return to normal eating. In direct, we had a flexible approach. If people had their own personal goals, wanted to stay on it longer, they could. The majority stayed on it a few weeks longer. Now, transferring back to normal eating, we managed by stopping the evening low-calorie diet shake and introducing a small meal that was very tightly specified in terms of quantity. Then, after people had got used to that, of a couple of weeks, we did the same at lunchtime, and a few weeks later did the same at breakfast time. So we have a stepped food reintroduction, and that's really important in dealing with real people battling with this huge change.
Okay, we have 4 questions and 4 minutes to complete the session. So the first telegraphic question, Andrea Giaccherini.
Short. Very short, very fascinating. I'm here. A little bit puzzled by the absence or even more important role of insulin resistance in your model, especially because when you remove lipotoxicity and glucose toxicity, you should observe some improvements in insulin resistance in skeletal muscle. It's true that it doesn't go back to normal, but some improvements should be there because we still remember that most of the glucose is supposed to go there. So if you ameliorate everything, there should be some improvements, and I'm puzzled by this.
Sure. I think the time clause is really important to recognize because over the 8 weeks of counterpoint, there was just this very slight increase at the end. If we express that as glucose clearance rates, then yes, it just became statistically significant. If we followed up for longer, I'm sure that exactly as you say, we would see a modest decrease in muscle insulin resistance. But the muscle insulin resistance field has really galloped a bit too fast because we need to really focus on what is the average of the normal and how far adrift these people are at this part of the spectrum with type 2 diabetes. Yes, we can increase muscle insulin sensitivity by weight loss and by exercise, but it's a modest change. It really has to be extreme to be a major change. So I think there we're looking at probably genetically determined factors. Certainly insulin resistance tends to cluster in families, probably for genetic as well as habitual reasons.
Leif, Professor Udrup.
Yeah, this is a little bit on the same line. Was insulin resistance a predictor of recovery from diabetes?
No. We looked at this and, well, it wasn't significant, but there was a tendency for people with higher fasting insulin levels to respond better. Now, I interpreted that as this flagging up the fact that these people had a beta cell that was heading towards being a null cell, and it was really struggling. So, yes, a slight tendency could be seen that wasn't statistically significant.
I hope you could do the clustering also in your patients to see, because, of course, it relates to what I showed yesterday, that for those who recover from diabetes after bariatric surgery almost exclusively belong to the insulin-resistant subgroup.
Yep. Almost everybody was pretty insulin resistant in this lot. You saw what happened to the liver component of the insulin resistance. So, as we said yesterday, we need to try and bring together these ideas.
Roy, I'm here. Thanks a lot. Excellent. Going back to this issue, so the predictors of the remission, you probably have already tried to understand who could be the best predictors. A question, is the initial body weight interacting with the amount of weight loss in giving a prediction of what is the improvement of the beta cell or other parameters, the remission, for example?
No.
It doesn't matter.
It doesn't matter if you're 150 kilograms or 70 kilograms. And so we see similar responses across the ballpark.
Another one, very, very fast. Do you think it's feasible not to use a liquid diet, a liquid formula, but just normal food, but keeping it to the 700-800 calories? And, yes. And in that case, do you think that in the macronutrient composition makes a difference?
Yes and no. In other words, yes, you can use any means of getting your weight down. And so just cutting back in general on food intake, if you achieve your 15 kilograms, you get the same effect. The speed doesn't matter. With regards to other approaches, intermittent fasting, yes. Mediterranean with low carb, yes. All of these are entirely feasible. This one was able to be used by most people, and that's what we were gunning for, because we need something that will start off and say, look, in most people, this works. With regards to the individual diets, some people will do well on each of them. And there's a further point.
if there are the proportion of lipids, protein, and carb?
Yeah,
because, in Italy, some people interpreted your study as supporting ketogenic diet. But the proportion of the macronutrients in the liquid formula was not in support of that. Do you confirm?
The liquid formula diet is actually high carbohydrate, so it's a very reverse. This ketogenic diet business needs to be put in a box. Any diet will cause this physiological increase in ketones. Come on, it's physiology. So, these enthusiasts need to be just calmed down a bit. Very low carbohydrate diets, well, they can have their problems. I wouldn't advocate a very low carbohydrate diet, but I can talk about the UK. This is crunch day for the UK in a few ways, but we still eat 50% carbohydrate, 50% of calories. The rest of Europe, I believe, including Italy, is 43 to 45%. And so this excess is probably not a good thing. But in terms of the general question, no, the macronutrients don't matter. What matters is what suits the individual. We find some people do very well on low-fat diets. Other people do very well on low-carbohydrate diets. So let's hear it for the individual and the family setting they eat in.
A very last question, Roy. Did you mention Roger Unger? Roger Unger and his biohormonal hypothesis, I think, is a very important one. In your experiment, in particular, in the 8 weeks first data you showed us, did you measure glucagon?
Not in that study, but we have measured it in other studies. The high plasma glucagon of type 2 diabetes completely normalizes. Now, there's an interesting modern twist to this Roger Unger story, in that Mimo Achille has shown, and others, including our own group, that there is evidence of alpha cell to beta cell transition in the recovery from diabetes. And in people with type 2 diabetes, there are lots of cells that co-localize. It was actually mentioned a few lectures ago. So I think we can say, yes, this is transdifferentiation. Those hidden beta cells were masquerading as alpha cells and pumping out glucagon. They, once the stress has been removed, obey the rules, turn into beta cells, the glucagon goes down.